Hello everyone, and welcome. I'm delighted to have you here today. Today's presentation is titled, Management of Carbapenem-Resistant Gram-Negative Bacteria, and I will be guiding you through this important topic. We'll explore the challenges posed by these resistant bacteria, current management strategies, and potential future directions. So, let's get started and delve into this critical area of infectious disease management. Today, we're focusing on some of the most challenging gram-negative bacteria that we encounter in clinical settings. First, we have carbapenem-resistant enterobacterales, which are a significant concern because they resist many of our most powerful antibiotics. Then, there's Stenotrophomonas multifilia, an emerging pathogen that's often resistant to multiple drug classes, making infections difficult to treat. We also need to be aware of Pseudomonas aeruginosa, with difficult-to-treat resistance. This organism is notorious for its ability to develop resistance quickly, limiting our treatment options. Next, carbapenem-resistant Acinetobacter baumannii is another critical pathogen, especially in hospital environments, as it can survive on surfaces and resist many antibiotics. All of these bacteria fall under the broader category of carbapenem-resistant gram-negative bacteria, which are increasingly a major threat worldwide. Understanding their resistance mechanisms and how they impact patient outcomes is essential for developing effective infection control strategies. This slide sets the stage for our discussion on the importance of recognizing and managing these resistant organisms in our ongoing efforts to combat antimicrobial resistance. Let's start by clarifying what CRE are. They are members of the Enterobacterales order that are resistant to at least one carbapenem antibiotic, such as ertapenem, meropenem, imipenem, or dorapenem. Alternatively, they may produce a carbapenemase enzyme, which breaks down these antibiotics. It's important to note that for bacteria like Proteus, Morganella, or Providentia, which are intrinsically less susceptible to imipenem, resistance to at least one other carbapenem is needed to classify them as CRE. CRE is a diverse group of pathogens with multiple resistance mechanisms. Broadly, we can divide them into two categories, those that produce carbapenemase enzymes and those that do not. The non-carbapenemase producers often develop resistance through amplification of other beta-lactamase genes, like ESBLs, combined with disruptions in outer membrane porins, which reduce drug entry. On the other hand, carbapenemase-producing CRE account for roughly 35% to 83% of cases in the United States. The percentage varies depending on whether we define CRE based on resistance to meropenem or imipenem specifically. In the U.S., the most common carbapenemase are K. pneumoniae carbapenemase, or KPCs, which are not limited to K. pneumoniae alone. They can be found in other species as well. Other types include NDMs, VIMs, IMPs, and OXA48-like enzymes. The NDM, VIM, and IMP enzymes are collectively known as metallobeta-lactamases, or MBLs, due to their mechanism of action. Understanding these mechanisms is crucial because they directly impact how we approach the detection, treatment, and containment of these resistant bacteria, which is a key part of our overall strategy to combat antimicrobial resistance. Beta-lactamases are a quite diverse family of enzymes that bacteria produce to inactivate beta-lactam antibiotics. They do this by hydrolyzing the beta-lactam ring, which is essential for the antibiotic's activity. Now, these enzymes are classified into four main classes, A, B, C, and D, based on their molecular structure and amino acid sequences. Think of it as a sort of genetic blueprint that helps us understand their differences. Within these classes, we also categorize them functionally, depending on how they hydrolyze antibiotics and how they respond to inhibitors. This dual classification system helps us see not just their structure, but their clinical relevance too. Let's talk about the molecular classification first, known as the Ambler classification. Classes A, C, and D all use a serine residue at their active site. This residue is crucial because it forms a covalent acyl enzyme intermediate during hydrolysis, essentially breaking down the antibiotic. On the other hand, Class B enzymes are quite different. They're called metallo-beta-lactamases because they require zinc ions at their active site to facilitate the hydrolysis process. Switching gears to the functional classification, which is the Bush-Jacobi-Medeiros system. This system groups beta-lactamases based on what antibiotics they can break down and how they respond to inhibitors. For example, Group 1 includes cephalosporinases, like AMP-C enzymes. Group 2 is broader and includes penicillinases, extended-spectrum beta-lactamases, or ESBLs, and carbapenemases. Lastly, Group 3 is mainly the metallo-beta-lactamases, the MBLs we just talked about. To give you some concrete examples, within Class A, we find ESBLs like TEM, SHV, and CTXM, which are notorious for breaking down many beta-lactams. We also have Klebsiella pneumoniae carbapenemases, or KPCs, which are a big concern because they can inactivate carbapenems. Moving to Class B, the MBLs include enzymes like NDM, IMP, and VIM. These are especially problematic because of their broad activity and resistance profiles. Class C includes the AMP-C cephalosporinases, and Class D features OXA-type carbapenemases, which are increasingly relevant in resistance discussions. So, understanding these classes and groups is fundamental because it directly impacts how we detect, treat, and manage resistant bacterial infections. It ties into the overall theme of how bacteria develop and share resistance mechanisms, making our fight against these pathogens more complex, but also more targeted when we grasp their enzymatic profiles. In this slide, we're looking at data from the CDC between 2017 and 2019 regarding carbapenemase-producing isolates. The key takeaway here is that the majority of these isolates, about 86%, carried the BLA-KPC gene, which is a major contributor to resistance. Other genes like BLA-NDM accounted for around 9%, while BLA-VIM was less than 1%. BLA-IMP made up about 1%, and BLA-OXA48-like was present in roughly 4% of cases. Now, when we look at the period from 2019 to 2021, there's a notable shift. The percentage of isolates with BLA-KPC decreased significantly to 57%, indicating a reduction in this gene's prevalence. Meanwhile, the proportion of isolates carrying metallo-beta-lactamase genes, like BLA-NDM, BLA-VIM, and BLA-IMP, rose to about 20%. Additionally, BLA-OXA48-like increased to 8%. Understanding which carbapenemase gene is produced by a clinical isolate is crucial because it guides our treatment options. Some of the newer beta-lactam antibiotics are specifically effective against certain carbapenemases. However, traditional phenotypic tests, such as the modified carbapenem inactivation method, can tell us whether a carbapenemase is present, but don't specify which one. As the epidemiology of these enzymes continues to evolve, it's becoming even more important for clinical microbiology labs to identify the exact carbapenemase genes present. Implementing nucleic acid or antigen testing helps us determine this precisely. Lastly, the treatment options we've discussed assume that the antibiotics chosen are active in vitro against the specific carbapenemases identified, which underscores the importance of accurate detection for effective therapy. Let's take a closer look at the treatment options for infections caused by carbapenem-resistant enterobacteriaceae, or CRE. For uncomplicated cystitis caused by CRE, the preferred treatments include nitrofurantoin, trimethoprim sulfamethoxazole, ciprofloxacin, or levofloxacin, but only if the bacteria are susceptible. These agents are effective mainly because they reach high concentrations in the urine, making them good choices when they work. In terms of alternatives, we might consider single-dose aminoglycosides, oral fosfomycin, but only for E. coli infections, colistin, ceftazidimavibactam, meropenem vaborbactam, imipnem cilastatin relebactam, or cefiderocol. It's important to note that fosfomycin isn't recommended for K. pneumoniae or other gram-negative organisms that often carry FOS-A genes, which can lead to treatment failure. Colistin can be effective, but there's a significant risk of nephrotoxicity, so caution is needed. Polymyxin B, however, is not recommended. Now, for more complicated infections like pyelonephritis or complicated UTIs caused by CRE, the preferred options include trimethoprim sulfamethoxazole, ciprofloxacin, or levofloxacin if the bacteria are susceptible. Additionally, newer agents like ceftazidimavibactam, meropenem vaborbactam, imipenem cilastatin relebactam, and cefiderocol are supported by clinical trial data. Aminoglycosides are considered suitable alternatives here as well. However, fosfomycin isn't recommended in this context because it doesn't penetrate the renal tissue well enough to treat parenchymal infections effectively. Overall, selecting the right treatment depends heavily on susceptibility patterns and the site of infection, emphasizing the importance of tailored therapy in combating resistant organisms. Let's take a closer look at the treatment options for infections outside the urinary tract caused by CRE that do not produce carbapenem. When the isolate is susceptible, meaning the mic is less than or equal to 1 microgram per milliliter, we often start with extended infusion meropenem or imipenem cilastatin. This approach helps maintain effective drug levels over time. However, if the bacteria are resistant to ertapenem, or if there's no susceptibility to carbapenems, then we consider alternative options such as ceftazidimavibactam, meropenem vaborbactam, or imipenem cilastatin relebactam. These agents are designed to target resistant bacteria more effectively. For infections where these options aren't suitable, tigecycline or eravacycline can be used, especially for non-bloodstream and non-urinary tract infections. It's important to note that while extended infusion carbapenems are preferred if the bacteria are susceptible, adding vaborbactam or relebactam can sometimes lower the mics even in bacteria that don't produce carbapenems. This might be because of other beta-lactamases, like ESBLs, that are overproduced. We should also be cautious about using combination therapy with polymyxins or aminoglycosides, as evidence shows this can lead to increased mortality and nephrotoxicity, which is kidney damage. Lastly, tigecycline and eravacycline are effective regardless of whether carbapenem is present because they distribute rapidly into tissues. However, this rapid tissue distribution means their concentrations in urine and serum are limited, so they're mainly useful for certain types of infections. Overall, understanding these nuances helps us select the most appropriate therapy for these complex infections. Let's review the rationale behind our antibiotic choices for KPC-producing Enterobacterales infections. All three agents, meropenem vaborbactam, ceftazidimavibactam, and imipenem cilastatin relebactam, showed activity greater than 95% against these pathogens in the United States. However, our panel slightly favors meropenem vaborbactam as the top option, followed by ceftazidimavibactam, and then imipenem cilastatin relebactam. This preference is based on available clinical outcome data, which is more limited for imipenem cilastatin relebactam, and also considers the potential for resistance emergence. In particular, ceftazidimavibactam has a higher likelihood of resistance development over time. Importantly, these agents tend to improve clinical outcomes and have less toxicity compared to older regimens, like polymyxins or aminoglycosides, which were used previously. It's worth noting that direct clinical trial comparisons between these agents, such as meropenem vaborbactam versus ceftazidimavibactam, are currently lacking. Now turning to cefiderocol, a synthetic conjugate combining a cephalosporin with a siderophore, it primarily binds to PBP3, inhibiting bacterial cell wall synthesis. Over 95% of KPC-producing Enterobacterales are susceptible to cefiderocol, making it a promising alternative, especially outside of urinary tract infections. However, we lack robust comparative effectiveness data specifically for KPC producers, so its use is more reserved. We suggest reserving cefiderocol for infections caused by MBL-producing Enterobacterales or glucose non-fermenting gram-negative organisms, given its unique mechanism. Next, for CRE infections not involving the bloodstream or urinary tract, agents like tigecycline or eravacycline are alternative options. These tetracycline derivatives distribute rapidly into tissues, but their concentrations in urine and serum are limited. Importantly, their activity isn't affected by the presence or type of carbapenemase. To summarize our approach, Meropenem vaborbactam, ceftazidimavibactam, and imipnem cilastatin relebactam remain the preferred treatments for KPC-producing Enterobacter infections. And cefiderocol serves as an alternative, especially when other options are limited or resistance concerns arise. So, to answer the key question, what are the preferred antibiotics for infections outside the urinary tract caused by CRE when KPC production is present? These three agents are our mainstay, with cefiderocol as a backup option. Let's take a moment to understand the rationale behind our treatment choices for MBL-producing Enterobacter, specifically those with NDM enzymes. Currently, there is no FDA-approved beta-lactam or beta-lactamase inhibitor that is effective against these NDM producers. So, we need to look at alternative options. Preferred antibiotics include a combination of ceftazidimavibactam plus aztreonam or monotherapy with cefiderocol. Now, why these? Well, NDM enzymes hydrolyze penicillins, cephalosporins, and carbapenems, making many traditional antibiotics ineffective. However, aztreonam is an exception because NDMs do not hydrolyze it. The catch is that NDM producers often produce other serine beta-lactamases, like ESBLs or KPCs, which can hydrolyze aztreonam. Here's where avibactam comes into play. It inhibits many of those other beta-lactamases, protecting aztreonam from being broken down. This combination has shown promising results. An observational study from 2019 to 2022 looked at 328 patients with MBL-producing infections, most bloodstream infections. Patients treated with ceftazidimavibactam plus aztreonam had a 22% 30-day mortality, which was better compared to 50% in those treated with colistin-based regimens. This suggests that this combination can really improve outcomes. When administering this combination, we need to monitor liver enzymes closely because of potential toxicity. Also, in rare cases where cefiderocol or the combination isn't suitable, say, due to allergies, we can consider other options, like aztreonam combined with meropenem vaborbactam or imipnem cilastatin relebactam, provided the bacteria don't produce OXA-type carbapenemases. But I should note, clinical data for these alternatives are limited. Cefiderocol is another preferred option for these infections. Though we lack direct comparative data between ceftazidimavibactam plus aztreonam and cefiderocol, both are considered effective choices for MBL-producing strains. Lastly, for infections outside the bloodstream or urinary tract caused by CRE with NDM or other MBLs, antibiotics like tigecycline or eravacycline can be used. They work independently of the carbapenemase type, offering additional options in certain scenarios. So, to sum up, the main approach is to use ceftazidimavibactam combined with aztreonam or cefiderocol alone as preferred treatments. These choices are crucial in managing these difficult-to-treat infections effectively. Let's take a closer look at the rationale behind our treatment choices for OXA48, like producing Enterobacter infections. First, it's important to note that over 95% of these isolates are susceptible to both ceftazidimavibactam and cefiderocol, which makes these two agents particularly promising options. However, when it comes to meropenem vaborbactam and imipnem cilastatin relebactam, their effectiveness is limited. This is because vaborbactam and relebactam don't seem to inhibit OXA48-like enzymes effectively, so even if laboratory tests suggest susceptibility, they're not the best choices in practice. While both ceftazidimavibactam and cefiderocol are expected to work against infections caused by these bacteria, cefiderocol is generally suggested as an alternative. The reason for this is partly because there's less clinical data available for cefiderocol at this point. Additionally, reserving cefiderocol for infections caused by other resistant organisms, like MBL-producing Enterobacter or certain non-fermenting gram-negatives, helps preserve its utility. Looking at clinical outcomes, an observational study involving 76 patients with bloodstream infections caused by OXA48-like producers showed that 12% of patients treated with ceftazidimavibactam died within 30 days. In contrast, the death rate was higher, at 26%, among those receiving alternative treatments such as polymyxins. This highlights the potential effectiveness of ceftazidimavibactam in managing these infections. For infections outside the bloodstream or urinary tract, tigecycline or eravacycline are viable options. Their activity doesn't depend on the presence or type of carbapenemase enzymes, which makes them useful in certain scenarios. So, to sum up, our suggested approach is to use ceftazidimavibactam as the first-line treatment for OXA48, like producing Enterobacterales infections. Cefiderocol remains a good alternative, especially when considering the overall clinical picture and bacterial resistance patterns. And to answer the key question, what are the preferred antibiotics for treating infections outside the urinary tract caused by CRE when OXA48-like production is present? The answer is ceftazidimavibactam as the primary choice, with cefiderocol as a backup option. When using newer beta-lactam agents to treat CRE infections, such as ceftazidimavibactam, meropenem vaborbactam, imipenem cilastatin relebactam, or cefiderocol, there's always a risk that the bacteria will develop resistance over time. This is a common concern with any beta-lactam therapy. Most of the data we have focuses on KPC-producing isolates, which are a common type of CRE. Resistance to ceftazidimavibactam, for example, often occurs because of mutations in the BLA-KPC gene. These mutations lead to changes in the enzyme, making it better at breaking down the drug, particularly ceftazidime. Interestingly, such mutations can sometimes restore susceptibility to carbapenems, but what that means clinically is still uncertain. When it comes to meropenem vaborbactam and imipenem cilastatin relebactam, resistance mechanisms tend to involve changes in outer membrane permeability and efflux systems. Basically, how the bacteria control what gets in and out. Additionally, increasing the copies of the BLA-KPC gene has been linked to resistance across these agents. For cefiderocol, resistance mechanisms are more diverse. They include mutations in the iron transport system, changes in AMPC beta-lactamases, and increased NDM enzyme expression. Notably, resistance to cefiderocol appears much more common in isolates already resistant to ceftazidimavibactam, about 83% compared to just 7% in susceptible ones. Most of the resistance data we have is for ceftazidimavibactam, mainly because it was the first of these new agents approved by the FDA for CRE. Unfortunately, there's limited data on how often resistance emerges with imipenem cilastatin relebactam and cefiderocol. So the key takeaway is that resistance can and does develop with all these agents, but the likelihood seems highest for ceftazidimavibactam. This highlights the importance of careful use and ongoing surveillance to preserve their effectiveness as much as possible. When a patient has recently been treated with ceftazidimavibactam and now shows signs of sepsis or a similar severe infection, it's important to consider using a different novel beta-lactam agent. This is especially true until we get the culture and antimicrobial susceptibility testing, or ASD, results back. The key here is that if the previous infection's ASD results show other beta-lactam antibiotics that might still be active against the organism, switching to one of those could be beneficial. For example, imagine a patient with a bloodstream infection caused by KPC-producing bacteria who was treated with ceftazidimavibactam about a month ago. If they come back now with symptoms indicating infection, it would be prudent to consider using an alternative like meropenem vaborbactam until we have the latest organism identification and ASD results. This approach helps us avoid potentially ineffective treatment and also reduces the risk of promoting resistance. Speaking of resistance, a key concern is the likelihood of CRE, carbapenem-resistant Enterobacteriaceae, developing resistance to these newer beta-lactam agents when used to treat their infections. This is an ongoing challenge, and understanding the risk factors and mechanisms involved is crucial as we continue to refine our treatment strategies. Let's discuss the role of tetracycline derivatives in treating CRE infections. These agents work independently of the presence or type of carbapenem, which is quite important since they can be effective across different resistance mechanisms. However, it's crucial to note that these drugs achieve rapid tissue distribution after administration, but their urine and serum concentrations are limited. This means they are not generally recommended for urinary tract infections or bloodstream infections. That said, tigecycline and eravacycline can be considered as alternative options for infections like intra-abdominal infections, skin and soft tissue infections, osteomyelitis, and respiratory infections, especially when we use the optimal dosing strategies. One common side effect to watch for is nausea and vomiting, which can occur in up to 20 to 40% of patients receiving these drugs. It's also important to highlight that, for tigecycline and eravacycline, CLSI breakpoints aren't established for enterobacteriales, although the FDA has set breakpoints, which guides us in their use. Focusing on tigecycline, there's actually more published experience with it for CRE infections compared to eravacycline. Interestingly, when high-dose tigecycline is used, say 200 mg IV as a single dose followed by 100 mg IV every 12 hours, the mortality differences between tigecycline and other agents tend to diminish. So, if we're considering tigecycline, the panel recommends using these high doses to improve outcomes. Regarding minocycline, the data are limited, and caution is advised if we choose to use it against CRE infections. As for amidacycline, another tetracycline derivative with both IV and oral options, the evidence suggests it has reduced potency against CRE and an unfavorable pharmacokinetic and pharmacodynamic profile. Therefore, amidacycline isn't recommended for these infections. Overall, while beta-lactam agents remain our preferred treatment, tigecycline and eravacycline are valuable alternatives when beta-lactams aren't active or tolerated. So, to answer the question, tetracycline derivatives have a limited but important role, mainly as alternatives in specific scenarios when other options aren't suitable. Let's take a closer look at the rationale behind these recommendations. Observational and clinical data have shown that using polymyxin-based regimens is associated with increased mortality and a higher risk of nephrotoxicity compared to other agents. This is a significant concern when considering treatment options. Additionally, issues around the clinical effectiveness of polymyxins, along with pharmacokinetic and pharmacodynamic data, and the accuracy of susceptibility testing, have led the CLSI to eliminate a susceptible category for colistin and polymyxin B essentially. This means we can no longer reliably categorize these drugs as effective based on current testing. Given these factors, the panel recommends avoiding polymyxin B and colistin for treating CRE infections, with one exception. Colistin may still be used as an alternative for uncomplicated CRE cystitis. However, polymyxin B should not be used for CRE cystitis because it is primarily eliminated through non-renal pathways, making it less effective in kidney infections. In summary, the suggested approach is to generally avoid these agents for CRE infections, reserving colistin only for specific cases like uncomplicated cystitis, and not using polymyxin B at all in this context. This aligns with our overall goal of optimizing both safety and effectiveness in managing these challenging infections. Let's discuss the rationale behind the use of combination antibiotic therapy for CRE infections. While combining antibiotics initially seems like a good strategy to ensure at least one active agent is effective, the data doesn't really support ongoing combination therapy once we've identified a beta-lactam that shows activity in the lab. In fact, continuing with a second agent doesn't seem to add much benefit and may actually increase the risk of adverse events related to antibiotics. For example, using multiple drugs can lead to more toxicity without improving outcomes. Moreover, there's no solid evidence that combination therapy prevents the bacteria from developing resistance, which is a major concern with CRE. It's also important to note that there's a lack of randomized trial data comparing new beta-lactam agents used alone versus in combination. The limited observational studies we haven't shown better results with combination therapy either. Considering all this, and taking into account the known toxicities of agents like aminoglycosides, fluoroquinolones, tetracyclines, and polymyxins, the panel doesn't recommend routine combination therapy when susceptibility to a preferred beta-lactam has been demonstrated. So, in summary, the current evidence suggests that adding other antibiotics to a beta-lactam isn't generally beneficial for CRE infections and may even cause harm. Therefore, the suggested approach is to use a single, effective beta-lactam agent whenever possible, rather than combining it with other antibiotics. Today, I want to talk about Stenotrophomonas multifilia, which is quite an interesting bacterium in the context of infectious diseases. It's a gram-negative, opportunistic pathogen that you often find in hospital environments, especially in patients with compromised immune systems. What makes it particularly noteworthy is its ability to survive in various conditions, including water and soil, but it can also colonize medical devices and cause infections. One of the key points to remember is that S. multifilia is inherently resistant to many antibiotics, which can make treatment challenging. Its resistance mechanisms include efflux pumps and enzymes that break down antibiotics, so we often need to use specific antibiotics like trimethoprim sulfamethoxazole for effective treatment. Connecting this to the overall theme of our presentation, understanding pathogens like S. multifilia highlights the importance of infection control and antibiotic stewardship in healthcare settings. Recognizing its role as an opportunistic pathogen reminds us why vigilance is crucial, especially when managing vulnerable patient populations. Stenotrophomonas multifilia is an aerobic, gram-negative bacillus that doesn't ferment glucose and is found everywhere in water environments. Although it's generally considered less pathogenic than some other hospital-acquired organisms, it has the ability to produce biofilms and virulence factors. These features help it colonize or cause infection, especially in vulnerable hosts like those with underlying lung disease, people who inject drugs, or individuals with hematological malignancies. Dealing with S. multifilia infections can be quite challenging. One key point is that, even though it can cause serious disease, it's often tricky to tell whether the bacteria is just colonizing or actually causing an infection. This is especially true in patients with conditions like cystic fibrosis or those on ventilators, where S. multifilia is often part of a mixed infection. That makes it harder to decide if targeted therapy is truly necessary. However, we must remember that S. multifilia can be a true pathogen, leading to significant health problems and even death, particularly in patients with blood cancers. In these cases, it can cause severe issues like hemorrhagic pneumonia or bloodstream infections. Another major challenge is treatment. S. multifilia carries resistance genes and mutations that make it resistant to many antibiotics. For example, it produces L1-metallobeta-lactamase and L2-serine beta-lactamase enzymes, which break down most beta-lactam antibiotics like penicillins, cephalosporins, and carbapenems, though not aztreonam. Additionally, it shows intrinsic resistance to aminoglycosides because of chromosomal enzymes. It can also develop multi-drug efflux pumps that reduce the effectiveness of drugs like TMP-SMX, tetracyclines, and fluoroquinolones. Plus, it has chromosomal SMQNR genes that further diminish fluoroquinolone activity. So, overall, managing S. multifilia infections requires careful consideration of its resistance mechanisms and understanding when it's truly causing disease versus just colonization. S. multifilia ASD determination can be quite challenging. The CLSI has set breakpoints for 6 antibiotics against S. multifilia, including cefiderocol, chloramphenicol, levofloxacin, minocycline, ticarcillin clavulanate, and TMP-SMX. However, as of 2023, breakpoints are no longer available for ceftazidime, which means it's no longer considered an effective treatment option for this pathogen. Additionally, manufacturing of ticarcillin clavulanate has been discontinued, and chloramphenicol is rarely used in the United States because of its significant toxicities. So, ultimately, we are left with just 4 agents for which we can provide interpretable antibiotic-like data to clinicians. This highlights the ongoing difficulties in reliably determining susceptibility and emphasizes the importance of understanding which antibiotics remain viable options in managing S. multifilia infections. When approaching S. multifilia infections, it's important to first recognize that isolating this bacteria in culture doesn't always mean there's an active infection. Often, it might just be colonization, so we need to carefully differentiate between the two to prevent unnecessary antibiotic use. If we determine there is an actual infection, there are 2 main strategies we can consider. The first is using combination therapy with at least 2 active agents. The preferred agents include cefiderocol, minocycline, TMPSMX, or levofloxacin, and we select these based on the clinical scenario. We typically continue this until we see clinical improvement, mainly because the supporting data for any one agent is somewhat limited. The second approach involves a combination of ceftazidimavibactam and aztreonam. While clinical data is limited, this combination is promising because of the way the enzymes produced by S. multifilia interact with these drugs. The L1-metallobetalactamase hydrolyzes ceftazidime, but not aztreonam, and the L2-serine beta-lactamase hydrolyzes both, but avibactam inactivates L2. By combining ceftazidimavibactam with aztreonam, we allow aztreonam to bypass inactivation and reach its target sites effectively. Surveillance data suggest that this combination is active against about 92% of S. multifilia isolates. So, in summary, the best approach is to either use 2 of the specified active agents or to combine ceftazidimavibactam with aztreonam, tailoring our choice to the specific situation and available data. Let's take a closer look at Pseudomonas aeruginosa, specifically when it develops difficult-to-treat resistance. This bacteria is known for its adaptability and ability to survive in challenging environments, which makes infections harder to manage. When resistance becomes difficult to treat, it often involves multiple mechanisms, such as the production of enzymes that break down antibiotics or changes in the bacterial cell that prevent drug entry. These resistance traits can significantly limit our treatment options and complicate patient care. Understanding these resistance patterns is crucial because it highlights the importance of antimicrobial stewardship and the need for developing new therapeutic strategies. Recognizing the threat posed by resistant Pseudomonas aeruginosa ties into the overall theme of combating antimicrobial resistance and emphasizes the ongoing challenges we face in infectious disease management. Let's take a closer look at MDR-P aeruginosa. This refers to P. aeruginosa that isn't susceptible to at least 1 antibiotic in 3 key classes where we normally expect it to be susceptible. These classes include penicillins, cephalosporins, fluoroquinolones, aminoglycosides, and carbapenems. In 2018, the concept of difficult-to-treat resistance, or DTR, was introduced. DTR is defined as P. aeruginosa that shows non-susceptibility to a specific set of antibiotics, including piperacillin tazobactam, ceftazidime, cefepime, aztreonam, meropenem, imipnem cilastatin, ciprofloxacin, and levofloxacin. Both MDR and DTR-P aeruginosa usually develop through a complex interplay of multiple resistance mechanisms. These include decreased expression of outer membrane porins like OPER-D, increased production or amino acid changes in Pseudomonas-derived cephalosporinase enzymes, often called pseudomonyl AMP-C enzymes, upregulation of efflux pumps such as MEX-ABOPER-M, mutations in penicillin-binding protein targets, and the production of extended-spectrum beta-lactamases like BLA-OXA10. It's also important to note that carbapenemase production, while a common resistance mechanism elsewhere, is relatively rare in U.S. isolates of P. aeruginosa. However, in other regions like Latin America and Asia, it can be quite prevalent, up to 69% and 57%, respectively, often involving enzymes like BLA-KPC or BLA-Vim. The panel strongly recommends that all clinical microbiology laboratories perform antimicrobial susceptibility testing, ASD, for MDR and DTRP aeruginosa against newer beta-lactam agents, including ceftolozane tazobactam, ceftazidimavibactam, imipnem cilastatin relebactam, and cefiderocol. Understanding local ASD patterns for DTRP aeruginosa is crucial. It helps us guide empiric antibiotic choices effectively, especially while waiting for specific test results. This approach ultimately supports better patient management and outcomes. When a Pseudomonas aeruginosa isolate tests susceptible to traditional beta-lactam agents such as piperacillin tazobactam, ceftazidime, cefepime, or aztreonam, or to fluoroquinolones like ciprofloxacin and levofloxacin, or even carbapenems, the general recommendation is to prefer prescribing an agent from the first two groups over carbapenem therapy. The main goal here is to preserve the activity of carbapenems for future infections that are increasingly drug-resistant. Now, in cases where the P. aeruginosa isolate isn't susceptible to any carbapenem, but still responds to traditional beta-lactams, this can happen in about 20 to 60% of carbapenem-resistant cases. That's often due to limited or lack of OPER-D production. OPER-D normally helps carbapenems enter the bacteria, but if it's missing or reduced, carbapenems aren't effective. In these situations, high-dose, extended infusion therapy with traditional agents is suggested to maximize their efficacy. For critically ill patients with isolates resistant to carbapenems but still susceptible to traditional beta-lactams, using newer beta-lactam agents such as ceftolozane tazobactam, ceftazidimavibactam, or imipnem cilastatin relebactam is also a reasonable approach. This strategy helps preserve these newer agents for future infections that may become more resistant, which ties back to our overall goal of antimicrobial stewardship and maintaining our treatment options. So, to sum up, when dealing with MDRP aeruginosa, the preferred antibiotics are often those that the bacteria still respond to, with a focus on preserving our most potent options for the future. In this slide, we're looking at upcoming tables that bring together the suggested approaches and the rationales behind treating different types of infections caused by drug-tolerant or resistant Pseudomonas aeruginosa. What this means is that we're consolidating the best strategies based on the specific resistance profiles of these bacteria. The goal here is to provide clear guidance on how to approach these challenging infections effectively. By understanding the rationale behind each treatment option, clinicians can make more informed decisions tailored to the resistance patterns they encounter. This overall framework helps us navigate the complex landscape of drug resistance, ensuring that our treatment strategies are both rational and targeted. It's an important step in optimizing patient outcomes in the face of these difficult-to-treat infections. Let's take a closer look at the table on this slide, which focuses on treating uncomplicated cystitis with antibiotics. The key point here is that the preferred antibiotics include some advanced options like ceftolozane tazobactam, ceftazidimavibactam, imipnem cilastatin relebactam, and cefiderocol. These are chosen based on clinical trials demonstrating they are not inferior to the more traditional agents used for urinary tract infections. Now, when we look at alternative options, tobramycin or amikacin, given as a single dose, are considered effective. The rationale behind this is that aminoglycosides are eliminated through the kidneys in their active form, which makes them particularly effective for urinary infections, and they tend to have minimal toxicity when used appropriately. It's important to note that, although these aminoglycosides are effective, there isn't a wealth of robust clinical data supporting their use specifically for cystitis, so we should keep that in mind. Lastly, fosfomycin, which you might hear about in some cases, isn't recommended here due to high failure rates. This is because of the presence of the FOS-A gene in Pseudomonas aeruginosa, which confers resistance and diminishes its effectiveness. Overall, the choice of antibiotics here reflects a balance between clinical trial evidence and the pharmacological properties of the drugs, especially renal elimination, which is crucial in urinary tract infections. This aligns with our broader goal of selecting effective, targeted therapy while minimizing resistance and toxicity. Now, let's take a closer look at the table on this slide, which outlines some key antibiotic options for treating pyelonephritis or complicated urinary tract infections. As you can see, the preferred antibiotics include ceftolozine tazobactam, ceftazidimavibactam, imipenem cilastatin relebactam, and cefiderocol. These agents are considered first-line because clinical trials have demonstrated that they are non-inferior to other comparator agents, meaning they are just as effective in treating these infections. However, it's important to note that the data we have is still limited, so we can't definitively say that one of these options is superior to the others. The choice often depends on individual patient factors and local resistance patterns. Now, for alternative options, the table highlights once-daily tobramycin or amikacin, which are aminoglycosides. These are effective for completing treatment courses because they have prolonged activity in the renal cortex, providing sustained antibacterial effects. But on the flip side, they do carry a significant risk, namely nephrotoxicity, that increases with longer durations of therapy. So, when selecting these antibiotics, clinicians need to balance their potent activity against the potential for kidney toxicity, especially in patients with existing renal impairment. Ultimately, this table underscores the importance of tailoring antibiotic choices to both the infection specifics and patient safety considerations, which is a central theme in antimicrobial stewardship. Let's take a closer look at the table on this slide, which discusses antibiotic choices for infections outside the urinary tract. The preferred antibiotics in these cases are ceftolozine tazobactam, ceftazidimavibactam, and imipenem cilastatin relebactam. These options are supported by a combination of in vitro activity, observational studies, and clinical trial data, giving us a solid foundation for their use. However, when these preferred options are inactive, intolerable, or unavailable, cefiderocol is suggested as an alternative. It's important to note that while cefiderocol offers a promising option, the data supporting its use are limited. The studies we have are small, and the overall evidence isn't conclusive. Observational studies indicate that using cefiderocol is reasonable in certain situations, but they don't demonstrate a clear advantage over the other beta-lactam/beta-lactamase inhibitors. So, in the context of overall treatment strategy, these choices should be guided by the specific circumstances of the infection and the available evidence. This table really highlights how we balance efficacy, safety, and available data when selecting antibiotics for infections outside the urinary tract. Let's take a closer look at the table here, which focuses on infection types, specifically MBL-producing DTRP aeruginosa. Now, in terms of preferred antibiotics, cefiderocol stands out as the main choice. This is because it has shown activity against these resistant strains, although it's important to note that MBL-producing DTRP aeruginosa isn't very common in the United States. However, it is more prevalent in other parts of the world, so awareness is key. As for alternative options, there aren't any listed here, which emphasizes that cefiderocol is currently the primary recommended agent. The rationale behind this preference is based on the susceptibility of MBL-producing isolates to cefiderocol, which is promising. That said, clinical data on its use against these organisms are still limited, so we need to interpret its efficacy carefully. Finally, the note about combining aztreonam with ceftazidimavibactam is interesting. It suggests that such combinations are unlikely to offer significant additional benefits over aztreonam alone. This is because DTRP aeruginosa often harbors multiple resistance mechanisms, making combination therapies less effective than we might hope. Overall, this slide highlights the importance of selecting antibiotics based on susceptibility patterns and the current evidence, especially when dealing with such resistant organisms. Let's take a closer look at Carbapenem-resistant Acinetobacter baumannii. This is a particularly concerning pathogen in healthcare settings. It's a type of bacteria that's become resistant to carbapenems, which are often considered antibiotics of last resort. When bacteria develop resistance to these powerful drugs, treatment options become very limited. Acinetobacter baumannii is notorious for causing infections in critically ill patients, especially in intensive care units. It can lead to pneumonia, bloodstream infections, and wound infections. The resistance makes managing these infections challenging and increases the risk of outbreaks. This highlights the importance of infection control measures and antimicrobial stewardship. Overall, understanding this pathogen emphasizes the ongoing battle against antibiotic resistance and the need for new strategies to combat these resilient bacteria. Carbapenem-resistant Acinetobacter baumannii, or CRAB, infections present significant challenges in healthcare settings. Managing these infections is particularly difficult for a few key reasons. First, CRAB is most often recovered from respiratory specimens or wounds, but it's not always clear whether it's acting as a colonizer or a true pathogen. This is especially tricky in medically complex patients who are already very ill due to underlying issues, like those on mechanical ventilation or with extensive burns. Because of this, it can be hard to decide if antibiotics are really needed or if the poor outcomes are due to the patient's underlying health rather than the infection itself. Second, once A. baumannii develops resistance to carbapenems, it usually becomes resistant to most other antibiotics that would normally be effective. This leaves us with very limited treatment options. For example, resistance to beta-lactams, including carbapenems and sulbactam, is often mediated by the production of OXA carbapenemases, like OXA23 and OXA2440. Sulbactam resistance isn't just about beta-lactamases. Mutations targeting penicillin-binding proteins, or PBPs, also play a role. Plus, CRAB isolates often produce additional enzymes, such as ADCs, which further limit the effectiveness of common beta-lactam antibiotics. Aminoglycosides, another class of antibiotics, are usually not effective because of modifying enzymes or methyltransferases that inactivate them. And fluoroquinolone resistance typically results from mutations in specific regions of the bacterial DNA, known as quinolone resistance-determining regions. Finally, an important point is that we lack comprehensive, comparative effectiveness studies for the most commonly used agents. This makes choosing the best treatment even more challenging. All of these factors underscore just how complex CRAB infections are and why managing them requires a nuanced understanding of resistance mechanisms and clinical context. When treating infections caused by CRAB, the use of an antibiotic regimen that includes a sulbactam-containing agent is generally recommended. The preferred approach is to use sulbactam durlobactam in combination with a carbapenem, such as imipenem cilastatin or meropenem, and to continue this treatment until we see a clinical response. Durlobactam plays a crucial role here as a beta-lactamase inhibitor. It effectively inhibits class A, C, and D beta-lactamases, like TEM1, ADC, and OXA enzymes, by binding to them and preventing sulbactam from being hydrolyzed. This allows sulbactam to reach its target, the penicillin-binding proteins or PBPs, and exert its antibacterial effect. It's important to note that durlobactam does not inhibit class B metallobeta-lactamases, such as NDM. Fortunately, these are rarely produced by CRAB isolates in the United States, so this isn't usually a limiting factor. Now, regarding adding imipenem cilastatin to the regimen, the clinical benefits are somewhat unclear. Some studies show that this combination can lower the MIC, or minimum inhibitory concentration, of sulbactam durlobactam by about 1 to 2-fold. This might seem small, but it could be significant because it potentially targets more PBPs. For example, sulbactam tends to bind to PBP1 and PBP3, while imipenem targets PBP2. By combining these agents, and with durlobactam protecting them from beta-lactamase degradation, we increase the chances that both drugs can reach their respective PBPs effectively. So, in summary, the overall approach for CRAB infections involves using a sulbactam durlobactam-based regimen in combination with a carbapenem, and tailoring the treatment until clinical improvement is observed. This strategy leverages enzyme inhibition, multiple PBP targeting, and optimal drug delivery to improve outcomes. When the preferred option of sulbactam durlobactam isn't available, an alternative approach is to use high-dose ampicillin sulbactam. Specifically, we aim for a total daily dose of 9 grams of the sulbactam component. It's important to combine this with at least one other agent, such as polymyxin B, minocycline, preferably over tigecycline or cefiderocol, to enhance efficacy. Now, keep in mind that ampicillin sulbactam doesn't have the same beta-lactamase inhibitor protection as durlobactam. So, the panel recommends using high doses to maximize the potential of saturating the PBP targets of sulbactam, especially since a significant portion may be hydrolyzed by beta-lactamases before reaching those targets. Ampicillin sulbactam is formulated in a 2:1 ratio, meaning, for example, 3 grams of the combination contains 2 grams of ampicillin and 1 gram of sulbactam. To achieve the desired dose, we often administer 27 grams daily, which equates to 9 grams of sulbactam. This can be given as extended or continuous infusions, such as 9 grams every 8 hours infused over 4 hours. In summary, this approach emphasizes high-dose, prolonged infusion strategies to improve drug exposure and efficacy when dealing with crab infections, especially when other targeted options are limited. Let's take a closer look at this table, which outlines the suggested dosing of antibiotics for treating antimicrobial-resistant infections in adults. These recommendations assume that the patient has normal renal and hepatic function, which is important because both kidneys and liver play key roles in drug metabolism and clearance. You'll notice the abbreviations at the bottom. CRCL stands for creatinine clearance, which is a measure of kidney function, and IV and PO refer to the routes of administration, intravenous and enteral, respectively. Understanding the correct dosing is crucial because it helps ensure the antibiotics are effective while minimizing potential toxicity. For example, dosing adjustments are often necessary for drugs that are primarily cleared by the kidneys, especially in resistant infections where optimal drug levels are vital. This table is a practical guide that can help clinicians tailor antibiotic therapy based on the patient's renal function and the route of administration, ultimately supporting the overall goal of effective and safe treatment of resistant infections. Let's go over some key antimicrobial dosing strategies for various infections. Starting with amikacin, for uncomplicated cystitis, a single IV dose of 15 mg per kilogram is generally sufficient. However, for pyelonephritis or more complicated urinary tract infections, the dose remains 15 mg per kilogram IV once, but subsequent doses and intervals should be guided by pharmacokinetic evaluation to optimize efficacy and minimize toxicity. Moving on to ampicillin sulbactam, the total daily dose should be 9 grams of sulbactam, administered either as 6 grams of ampicillin plus 3 grams of sulbactam every 8 hours, infused over 4 hours, or as a continuous infusion over 24 hours with 27 grams total, meaning 18 grams of ampicillin and 9 grams of sulbactam. This flexibility helps tailor therapy based on patient needs. For cefepime, dosing depends on the infection type. For uncomplicated cystitis, 1 gram IV every 8 hours, infused over 30 minutes, is common. For more severe infections, such as other complicated cases, 2 grams IV every 8 hours, infused over 3 hours, provides broader coverage and better tissue penetration. Cefiderocol is administered at 2 grams IV every 8 hours, infused over 3 hours. In patients with a creatinine clearance of 120 ml per minute or higher, the dosing frequency increases to every 6 hours to account for faster clearance. Ceftazidimavibactam is typically given as 2.5 grams IV every 8 hours, infused over 3 hours, ensuring sustained drug levels for effective bacterial kill. When combined with Astrionom, both drugs are administered simultaneously via Weisite, with Astrionom at 2 grams IV every 8 hours, also infused over 3 hours, to maximize synergy against resistant organisms. Finally, for Meropenem vaborbactam, the recommended dose is 4 grams IV every 8 hours, infused over 3 hours, providing potent coverage especially for resistant gram-negative infections. Overall, these dosing strategies highlight the importance of tailoring antibiotic regimens based on infection severity, pharmacokinetics, and individual patient factors to optimize outcomes. Let's take a closer look at the antimicrobial options listed here. First, minocycline is administered at 200 milligrams either IV or orally every 12 hours, offering flexibility depending on the clinical setting. Moving on, nitrofurantoin, specifically the macrobid formulation, is given at 100 milligrams orally twice daily. But for those who need a faster onset or can't tolerate oral meds, there's an oral suspension option at 50 milligrams every 6 hours. Next, plasmicin is used mainly for uncomplicated cystitis at 15 milligrams per kilogram IV as a single dose. But for more severe cases like pyelonephritis or complicated urinary tract infections, the dosing remains 15 milligrams per kilogram IV once, with subsequent doses tailored based on pharmacokinetic assessments. Polymyxin B's dosing isn't specified here, so it's important to refer to the international consensus guidelines for precise administration details. For sulbactam durlobactam, the standard dosing is 1 gram of each component every 6 hours, infused over 3 hours. However, if a patient has a creatinine clearance of 130 ml per minute or more, the regimen shifts to every 4 hours, still infused over 3 hours, to account for faster clearance. Tigecycline starts with a 200 milligram IV loading dose, followed by 100 milligrams every 12 hours. This helps maintain effective levels for serious infections. Tobramycin dosing depends on the infection type. For uncomplicated cystitis, it's 5 milligrams per kilogram as a single IV dose, but for pyelonephritis or more complicated infections, the dose increases to 7 milligrams per kilogram once, with subsequent dosing adjusted based on pharmacokinetic data. Finally, trimethoprim sulfamethoxazole is used at 160 milligrams of the trimethoprim component every 12 hours for uncomplicated cystitis. But for other infections, the dose increases to 10 to 15 milligrams per kilogram per day of trimethoprim, divided into doses every 8 to 12 hours. Overall, these dosing strategies highlight the importance of tailoring antimicrobial therapy based on infection severity, patient-specific factors, and pharmacokinetic considerations to optimize outcomes. Let's go through the dosing guidelines for some key antibiotics used in urinary tract infections. Starting with ceftolozane tazobactam, the recommended dose for uncomplicated cystitis is 1.5 grams given intravenously every 8 hours, infused over 1 hour. For all other infections, the dose increases to 3 grams IV every 8 hours, but this is infused over 3 hours to accommodate the higher dose and ensure proper tolerability. Moving on to ciprofloxacin, which can be administered either orally or IV. For uncomplicated cystitis, the typical dose is 400 milligrams IV or PO every 12 hours. For more complicated infections, the dosing can be 400 milligrams IV every 8 hours or 750 milligrams PO every 12 hours, depending on the severity and patient needs. Next, let's touch on colistin. Since dosing guidelines for polymyxins like colistin can vary, it's best to refer to international consensus guidelines, such as those outlined by Tsuji and colleagues in 2019. For eravacycline, the standard dose is 1 milligram per kilogram per dose, given IV every 12 hours. Eravacycline is often used for resistant infections, so dosing precision is important here. Ertapenem is administered as 1 gram IV once daily, infused over 30 minutes. It's convenient for outpatient therapy due to its once-daily dosing. Fosfomycin is unique in this list because, for uncomplicated cystitis, a single dose of 3 grams PO is usually sufficient, making it a convenient option for uncomplicated cases. Gentamicin dosing depends on the infection. For uncomplicated cystitis, a single dose of 5 milligrams per kilogram IV is typical. However, For pyelonephritis or complicated urinary tract infections, the dose increases to 7 milligrams per kilogram IV once, with subsequent doses tailored based on pharmacokinetic evaluations. Imipnem is dosed at 500 milligrams IV every 6 hours, infused over 30 minutes for uncomplicated cystitis. For other infections, especially if feasible, extending the infusion to 3 hours can improve drug exposure. Similarly, imipnem relebitam is given as 1.25 grams IV every 6 hours, infused over 30 minutes, which helps maintain effective drug concentrations. Levofloxacin is straightforward, 750 milligrams IV or PO every 24 hours, applicable across various infection types. Finally, meropenem has a dose of 1 gram IV every 8 hours for uncomplicated cystitis, infused over 30 minutes. For more severe infections, the dose increases to 2 grams IV every 8 hours, and infusing over 3 hours can be beneficial if feasible. Overall, these dosing strategies highlight the importance of tailoring antibiotic therapy to the type of infection and patient-specific factors, ensuring efficacy while minimizing resistance and toxicity. This slide doesn't contain enough information. That's why we're moving to the next slide.